So thank you for the opportunity to be here and speak with all of you. Fascinating two previous studies. I'll try not to repeat things that I've heard already, and maybe more just to illustrate where we are with adjuvant treatment currently, and I think we've maximized it, but I'll conclude with that as well. So, just to put things in context, in all solid tumors, we're actually declining in mortality rates in men and women, and the only two solid tumors that we're still increasing mortality rates are pancreatic cancer and liver tumors. So this is just to show you where we are in the context of a world problem. This is a very tough disease. 80% of the patients who have resection and adjuvant treatment are going to relapse, and only 20 of our patients are going to be operable, so we have a tough time. What we and others have shown that there does seem to be a subset of patients that we define as outlier patients that are actually doing a little bit differently and maybe a little bit better. We just don't know how to define these patients, maybe by immune profile and maybe by other profiles that we'll discuss later. So I think that this audience is very knows pancreatic cancer, and we're really dealing with something that we don't know how to diagnose and define early. And we see this early invasion of metastases as really a metastatic systemic disease up front. I think that's how we all have to look at pancreatic cancer and give it the credit. And then also our patients coming with very debilitating symptoms. So the criteria for the resectability changes amongst different states, different institutions, and different countries. This is very, very confusing when you try and look at clinical trials and put the studies together. And it was also illustrated previously. This is more or less the guidelines that we use, but those are the truly resectable cases. And then the locally advanced cases are quite easily to take out of this basket. And actually the borderline cases are the ones that can really fall sometimes in different places depending on the country. Staging of resectable pancreatic cancer, so we have our CTs, we like thin slices of course. Sometimes endoscopic ultrasound can be superior in actually visualizing the tumor and its proximity to the blood vessels, and then MRI and MRCP. And we heard also about using laparoscopy. We have discussed this also in our institution, and I know it does come up. I think that going ahead and thinking about clinical trials, we may have to be a little bit more, I would personally probably be more favorable about doing laparoscopy if we're really wanting to define the staging of our patients as accurately as we can. So that's a good option. So these are the patients that I'm supposed to be speaking about, because really only the resectable patients are the ones that should be going into clinical trials and having adjuvant treatment. The borderline, fallen kind of now into the neoadjuvant approach, but some of the studies that I'm going to still show you had this mix of these patients, well, actually all the studies. So this is where we are in 30 years of adjuvant treatment in pancreatic cancer. When you think about other diseases, breast cancer and other diseases, this is quite a difficult slide to see. This is really where we are. What I do find interesting when you look at that, is that we kind of already in 1985, we got to our 20 months. The highly selected group, yes, I know there's lots of flaws with that clinical trial, and there's a lot of problems with it. However, we kind of already got to our 20 plus months in overall survival. And it really took us a long time to pass that number. But, that's kind of the last 2 decades until modified gemcitabine, we kind of stayed in the 20-month range. If I look at only older studies, the ones published till 2010, what one can see as what I've just illustrated is that we already had our 20-month overall survival, and then then we saw that gem was better than observation, but really not much. I don't think you can, this is not very, very impressive, but we are getting better in the observation arm. So we obviously are, treating our patients better, giving them better post-operative care. medical treatment overall. So this is improving just our overall medical care. However, when one looks at also R1 resection rates, sometimes they're very low, but actually they're always really very high. And this has also been a narrative that has come up in the two previous talks. So once again, just showing the differences between the trials. So now I'm going to just kind of go through the major oncology adjuvant trials that were, and just try and illustrate a few points. And then maybe like the last trial, the recent modified FOLFIRINOX, we'll try and stick on that a little bit more. So one can see that Congo 001 randomized patients to gemcitabine versus observation. And one can see that 5-year overall survival seemed to be quite, a little bit better. But 10-year overall survival doesn't seem to be as much. So we really, a lot of our patients fall off at the beginning from recurrent disease and death, and then afterwards, we can still maybe not think about, the terminology we should use. Maybe we should be very careful about not talking about a cure. It's more like a remission in pancreatic cancer. And that goes back to the previous definition. Even though here I am as a medical oncologist speaking to surgeons, we really are speaking about a systemic disease with a systemic problem. And I think we always have to think about pancreatic cancer in that way. And this is different to colon cancer or breast cancer or other diseases. SPAC 3 showed us, and this is, I think about this trial, and I think about drug development, and I think about finances, and I do applaud the SPAC for doing this trial, but this is a 1,000-patient study. A 1,000-patient study to say that, adjuvant gemcitabine and 5-FU are really similar, toxicity profiles a little bit different. So, it's not that I've done personally anything better, it's not that I'm, going against that, but I think that we do have to be very thoughtful when we design clinical trials, what question we're asking, and how many patients and efforts are we going to actually use, and what questions we're going to get back from those, those answers that we are being answered. SPAC 4 trial, this was the follow-up study, so this actually randomized patients to gemcitabine versus gemcitabine and capecitabine, and this was an effort led by UK, Sweden, France, and Germany. About 700 plus patients, as I say, randomized for these two things. The cure was very quick, and one can see that at around median overall survival was slightly better in the gem capecitabine versus gem, but hazard ratio of about 0.82. This is statistically significant, but when we think about, once again, approval of drugs and drug development going forward, it's not a highly robust hazard ratio, that's what I would say. 5-year overall survival, though, seemed almost twice as much, so this was encouraging, and we still have to see, longer overall survival to see what happens, because we could see in the earlier trials that when you get to around 10 years, it doesn't seem to maintain that overall survival, which is, once again, a little bit frustrating when you think about what we're trying to deal with. R1 resections, balanced in both arms. So, and then when you look at no positive patients, once again, almost balanced in both arms. And here I would like to just stop a little bit and look at this slide. So when we look at the resection margins, if you were positive, you didn't really seem to benefit with the more aggressive chemotherapy, the combination of gemcitabine and capecitabine. However, if you were a margin negative, then you did. And one can see here in the light blue line, these are patients receiving gemcitabine alone with positive margins, and this kind of light pink line, which is capecitabine with margins positive. And one can see that median overall survival for those was exactly the same, 23 and 23, right? So there's actually no difference if you have a margin positive, which is a little bit kind of confusing. You'll see the next data that I'm going to show you, because you would think that a more aggressive approach, you might get, a better overall survival. However, in the margin negative, there's a nice, I would say, a nice break between the blue line and the red line. So 27 to 38, right, 39. The conclusions from this paper was that, median overall survival was significantly higher in GEM-CAP, and this has become a new standard in the Western world. With slightly more toxicity, we do see it in our patients when we treat them. We do have to manage our patients, select for them differently, sometimes kind of stagger on the treatment, so we would maybe start with one chemo and then add the other. And then marginal effect, they said that sometimes you see just a marginal effect in an advanced setting. This can be translated into a bigger effect in another setting. And this became a new standard of care. And then the French study, this was very highly applauded. I'm also very impressed by the French that get together and can do randomized clinical trials without pharmaceutical support. That's really a very difficult thing. A lot of our American colleagues actually aren't managing to do that at a high success rate. And here we can see in the Europeans and the Dutch really applaud the previous works. Just discussing that, it's really impressive in today's modern world where people only want to put money and funding in, in pharmaceuticals and exciting new drugs are involved, and in these cases it's not. So just some study characteristics to note: that R2 resections were excluded, and patients with a CA99 above 180 were excluded. It's important. And then any patients with, any GI toxicity post-op were also excluded. And this is, obviously due to the toxicity profile of FOLFIRINOX, which has such severe GI toxicity. So this is actually something that I wanted to show you, that in metastatic disease, we did see the benefit of FOLFIRINOX versus gemcitabine and also gemnab-paclitaxel, and that's, provided the rationale of bringing it forward now. But one must remember that we don't always see protocols or combination treatments that have proved to be efficacious in metastatic disease don't always translate to be efficacious in adjuvant disease. We've learned those lessons with colorectal cancer, for example, FOLFIRI. Disease-free survival was significant, 21 months versus 12 months for gemcitabine, so superior in the FOLFIRINOX arm. Median overall survival, 54 months for modified FOLFIRINOX versus 35 for gemcitabine. Let's stop and think about that number. So what does it mean that gemcitabine now can give you 35 months and we haven't seen that previously? How does that make any sense? So this actually, this is thanks to courtesy of the slides, or thanks to Colin Weeks, a colleague of mine, who gave a very nice commentary on that. So when you look at this slide, it really illustrates for us why gemcitabine, so-called, is doing better now. So if one looks at SPAC4, gem versus gemcap, so median overall survival for gemcitabine was 25 months, and now it's 35 months in the gem arm in the French study. However, disease-free survival is exactly the same. So what we can learn from that is that we are just giving our patients, when they do recur, more, maybe more robust chemotherapy protocols, and that's why we're improving their median overall survival. It's making sense? So once again, disease-free survival is the same in both arms, in SPAC4 and in the French study, but the actual median overall survival was much higher in the French study. This is probably, that we actually give metastatic disease superior treatment. Those patients, most likely went on to receive FOLFIRINOX. And then this is something I'd also like to stop a moment and think about, and I'd like to take you back in thoughts to our SPAC study when we gave GEM and GEMCAP, and I showed you that if you have if you have margin positive, you don't actually benefit so much at all actually from GEMCAP. And here we see exactly the opposite. So if you have, here we've got completeness of excision, so it's R0, R1. So here, if you are positive, you're actually having a much better benefit for FOLFIRINOX. And if you are negative, then maybe not. So we can start thinking about how we want to, select our patients. Is this just by chance? Are we trying to compare studies that were done in slightly different areas? Are we over-interpreting? Maybe yes. I don't know. But it is something, food to thought when you're sitting in front of your patients and you're trying to decide on adjuvant treatment. And you've got like a 73-year-old who's not quite here, not quite there. So, this can maybe, for me personally, this would come as a factor that may, encourage me to give, if he's R1 positive, I would maybe give FOLFIRINOX, and if he's negative, I may give gemcitabine. But please take me with a grain of salt, because I think that this data is still, it's hard to do cross-trial analysis and to make these big assumptions. Once again, disease-free survival, superior, and metastatic-free survival also. So this was these were the summary of that trial. So we know that it is a very good adjuvant protocol for patients that can receive it. And this is only really a fraction of our patients. You as surgeons who send us the patients, I'm sure you kind of lift your eyes and think, okay, what are the oncologists now going to do? And then we see the patients and we go, oh my gosh, what are we now going to do? So that is like the real life scenario. And unfortunately, it's really it's the bread and butter of what we do, and it's the majority of our patients that we see. But now and then we do have these patients that we can be more thoughtful about, and we can think what to give them. So this is for patients highly selected. Once again, they don't have all these GI toxicities post-op. The diarrhea is very debilitating. I often kind of scratch my head and think, what do I really do with these patients? And I think that you as surgeons have the same thing. And this whole impact of R1 resection, and how can we really think about that? And then another thing that was brought up, and I'd like to stop and think about it a little bit altogether, is what about subsected patients? So we can subsect patients, outliers as we may call them, by some kind of immune response signature. Studies are very started to show that. So when you have this T-cell infiltrating subpopulation, some of these patients are showing superior overall survival, and by using other immune signatures, as we so elegantly saw earlier. And we also know that we have patients that have some kind of repair defects in their tumors. So they have, what we know is homologous recombination defects, and the patients that are the patients that typically are the homologous recombination defects are the patients with a BRCA1 or 2 mutation. And one could think that these patients, when we give them chemotherapy, the cancer cells, which we know they're there, right? Metastatic cancer cells are always there almost, in pancreatic cancer. So when we see these cells, and if we can, give chemotherapy to these patients, maybe the effect of chemotherapy may be different in these patients. And we others have shown this repetitively. And in the metastatic disease, we are identifying these BRCA patients or BRCA-like patients or patients with other homologous recombination defects like RAD51, etc. And we're trying to, first of all, capture them. And we're trying to think about how we deal with them maybe in a more tailor-mannered. And we've got an effort here also led by Nia Lubetsky from Ichilov that together with us, and that we're trying to think about how this affects the neoadjuvant approach. Okay, so if we're going to, if a patient has a tendency to maybe have a high efficacy to chemotherapy X that we're going to give them, we want to try and see how that translates to his maybe, complete pathological response or other parameters that we're going to look at when we look at post-op efficacy essays. Other adjuvant trials are in progress. Is the gem-nab paclitaxel versus gemcitabine. I doubt, at least in my career, that there'll ever be a head-to-head comparison of gem-nab versus FOLFIRINOX. So I think that what's going to happen for the medical oncologist and the surgeon kind of sitting and watching what we do is, I think it's going to be quite challenging how we're going to have to actually identify patients and treat them and decide which should get what protocol. I'm coming to the end. So once again, current post-op trials are difficult to interpret. Eligibility criteria are so different. And we've got so little trials in 20, 30 years. And we're kind of doing this cross-trial analysis. So that's fine, but we must just keep this in mind. And then this poor resectability criteria has allowed, all different patients to join. And this whole story about the R1, R2 resections. Post-op trials are very difficult to interpret, and I say as a community we should think about doing structured templates for operative and pathology reports. This would really help us to analyze our data in a more academic way together. And then we're starting to see now how this combination chemo with the FOLFIRINOX kind of let us get above those 20 plus months that we've seen previously. We do lack predictive biomarkers. However, if we think about the things we've spoken about, the immune profile or subsets like the homologous recombination defects, then we can think about how we can use this to perform more educated clinical trials going ahead. So I'm a medical oncologist, but I think I would always say to all of you, let's give the neoadjuvant approach up ahead. We are dealing with a systemic disease. I can't even say cure, even patients when I've seen 4 or 5 years out, I just think about remission, and so I think that we should all think about that as well. And just some food for thought. This has been previously also said by the previous speakers so elegantly, but that we have to be very methodical about getting pre and post-treatment biopsies. We have to think about not only how we capture those biopsies, so if we're using a slightly larger needle, so we can get core and not cytology. We've got to think about how we're preserving that. Are we preserving it fresh frozen? Are we doing FFP? We've got to be thoughtful about that. Are we getting blood as well? We may want to look afterwards at other assays and combine. And it's okay when you go ahead and you plan your clinical trial, or even if you're just doing something in-house, even if you haven't decided what you're going to do with all these exploratory assays, you can still capture all your patients' tumor samples in the best way possible that you know. The crosstalk, and that's what we're having here at this lovely meeting. It's really been nice for me to be here. This really gets us thinking, and and all sitting together as the Israeli community. And then all these novel trials, we have to just think about using predictive biomarkers, and we have also this population in Israel, so we can think about that. There's one slide to put it all together, but we've gone through all this data. So just to summarize, so our chemotherapy does stabilize more patients as we're giving more and more chemo, and yes, we're really knocking our patients out. I say this and with kind of my heart really kind of sinks when I say it, because it's true. We really do. Our patients pay a terribly high price for the most aggressive protocols that we have in solid tumors we give us to our pancreatic cancer patients. So there's a big price for this increase of overall survival and disease stabilization. We've spoken about accurate patient identification and selection of adjuvant treatment. And this is something that we can also think maybe more, more about. The nutrition, physical and emotional aspects that we think about as a team when we treat our patients together. And I think that out of almost all the cancer patients, I think the gastric cancer patients and the pancreatic cancer patients really need this more than others. And then really to do as many biopsies as we can, to get biopsies, to capture them, to preserve them in the best way, and then we can, get together. And of course the neoadjuvant setting is the better setting. So even though I had to speak about adjuvant, I'm for the neoadjuvant approach.
Thank you very much.